Welcome to today's clinical posting. We are discussing 14-year-old female patient presenting with symptoms of cough, dyspnea, and fever. The patient has a known history of asthma. Let's dive into the patient case. A 14-year-old female present to the clinic with 4 days history of persistent cough, difficulty breathing, dyspnea, and fever. She has a past medical history of asthma managed with inhaler. Her parents report that the cough has been worsening and is associated with wheezing and shortness of breath, especially at night. There is no significant history of recent travel, contact with sick individual, or significant environmental changes. On examination, the patient appears anxious, is in mild respiratory distress. Her respiratory rate is increased, and there are bilateral wheezes on auscultation. The rest of the examination is unremarkable. Based on clinical presentation and differential diagnosis, we proceed with few key investigation. First, chest X-ray. The chest X-ray show no consolidation, ruling out bacterial pneumonia. There is evidence of hyperinflation, which is consistent with asthma exacerbation. Second, complete blood count. The CBC reveals elevated WBC count, primarily neutrophil, indicating a possible bacterial infection. However, the eosinophil count is normal, which is less suggestive of allergic asthma exacerbation. Then last one is a peak respiratory flow rate. The patient PEFR is significantly reduced compared to her baseline, further supporting to the diagnosis of asthma exacerbation. Then atrial blood gas. ABG show mild respiratory alkalosis, suggestive hyperventilation due to difficulty breathing, a common finding of asthma exacerbation. This investigation helped confirm that the most likely diagnosis is an acute asthma exacerbation, likely triggered by viral infection given the absence of bacterial finding and the patient history of asthma.